You're fine. Can everyone see that?
Yes.
I'm gonna make it bigger. Just give me 1 second. All right. I think we're good.
So this was the topic that I don't know if I actually chose it, but I was asked to just do drugs and diabetes. So just a few on the classifications. This is actually maybe even a little too simplistic, but potentially can give you some quick key points to think about in each of the classifications of drugs. Next slide. So I got this all from basically the ADA and or just using some of the inserts from some of the drugs class, but metformin is your first line. So everyone should be trying to get your patients to be able to tolerate the drug. It is a gluconeogenesis suppression of it and to improve glucose uptake and insulin sensitivity. Again, the side effects that are most annoying to the patient are obviously the GI side effects, but trying to get patients on the lowest dose is also beneficial. Maybe not 500 once a day. I tend to use that on PCOS types of patients, but if you can get a patient to at least be on 1,000 daily, it works very well in conjunction with the newer agents, SGLT2s and your GLP drugs, to improve the efficacy of those. Metformin is also obviously no hypoglycemia with it. That's huge for patients too, to make sure you're reiterating that to them and develops a confidence in the medication that they don't have to worry about that. There are renal consequences with, and everyone kind of knows that, but the less than 45 using GFRs and also looking at creatinine as well, and then stopping the medication when GFRs are less than 30. Teaching patients, a lot of times they're like, well, I don't want to be on that, it hurts my kidneys, and just trying to explain that it actually is going to help protect, because if you improve the blood sugars, it'll protect the kidneys. It doesn't cause kidney damage, but if there is kidney damage, then we can't be using it. Teaching patients also, we'll talk about this with SGLT2s, that lactic acidosis. So during phases of dehydration, vomiting, severe diarrhea, they're in bed, they're just not really eating, it's fine for them to not take their metformin. Sure, their blood sugars are going to rise, but the consequences of dehydration and lactic acidosis during that period of time is much more concerning. So great cost on it, the extended release forms. Encourage that with your patients too. I get a lot of, I don't question it, but I do get a lot of patients that kind of come in on extended release, not daily, but it's twice a day. I utilize that a lot when patients have GI side effects too, even though it's a twice a day medication, I separate it. I said, even though it can be a once a day, I separate it out. But also make sure you're also questioning the patient. Sometimes they just take it twice a day because they always have, and that second dose gets missed. So using the XLs or the ERs to try to get it into daily will help improve compliance. Next slide. Sulfonylureas in endocrine world, not primary care. We stop this drug a lot because primary cares have already started it. There's all your generic names for them, as well as the trade names for you. But this is the mechanism, is to increase insulin production from the pancreas. This one does cause low blood sugars. It's been around for a long time, so the confidence of using these drugs and that they work is another thing. They work until they run out, and so that's where you can get the low blood sugars, and we'll talk about that. Sulfonylureas are also used for MODY, so when that is diagnosed, that's the drug of choice for that. And then I have here usually a fast onset, so you take the medication, you're going to see a 30 to 1 hour onset of the drug. Next slide. So when you want to start these, look at them, consider what are some of your goals that you want to have. So sulfonylureas is not a metformin, so you do want to be checking blood sugars. They should not be these patients that don't want to check blood sugars. Already talked about hypoglycemia. And if you do have CKD, it's not that these drugs can't be used, but no, these drugs are going to hang around longer and in turn sometimes cause some of those unexpected low blood sugars. if your patient is on insulin, there is really no reason to continue sulfonylureas. So you will struggle with what caused the low. Was it the insulin or was it the sulfonylurea? So we see that a lot coming to us, that they're got started on insulin and they're still on their sulfonylureas. Yes, you'll have to use less insulin, but the risk of seeing some low blood sugars and not really being able to determine which one caused it is the issue with it. So usually you should stop it when you're starting that. And then we already talked a little bit about side effects. And a lot of people like the sulfonylureas due to not having those GI side effects. Next slide. DPP4s, they're the gliptins. If you look at all those generic names there, the sitagliptin, linagliptin, those are probably the two that I see the most, is the Januvia and Tradjenta being used. We don't have the Galvus, that's not in the United States, but you see it in the package inserts for these drugs. So this blocks the DPP enzyme and it destroys the hormone endocrine. And endocrine is a hormone that helps the body produce more insulin and when it is needed. And it reduces the glucose being produced by the liver or being spit off by the liver. So it just inhibits this hormone to help control blood sugars. These are some of the great things about it. It is a weight neutral drug. So a lot of patients, females specifically, are concerned about that. It's a great elderly drug. So you don't want to induce low blood sugars, but you need an additional agent. Then we'll say that there's no major risk. It says lowers risk of bone fractures. That's probably the positivity of it, that why sometimes maybe you would want to keep them on this drug. But really, when you get to needing insulin again, this would be another drug that you're kind of not getting a whole lot of bang for your buck. So to cost or an additional copay, you might as well just keep them on insulin and maybe a couple extra units to make up for what this DPP4 could do. There are renal adjustments. They're on two of them, but the Tradjenta is a benefit because there is no renal adjustment on it. Next slide. So these are the considerations. Again, it's low potency, so you're not going to get a whole lot of bang for your buck. So patients that need an A1C moved 2%, 3%, it's probably not going to do it. But someone just needs tweaked would be a good consideration. Again, the elderly, so it's not going to induce those low blood sugars. We say do not use this with GLP drugs, and that's real about the mechanism of action. So just like sulfonylureas, it's not that you can't do it and you're doing them any harm, but sulfonylureas and insulin together, you kind of don't know what's causing the low. So GLPs and DPP4s together, you're working along the same mechanism of action with the integrin hormone, and so you're not getting an additional bang for your buck on it. So if you add GLPs, you probably should remove your DPP4s. Renal functions, as I said on the previous one, there's two of them that you'd have to use lower doses if they had lower GFRs and creatinins. And as with most pancreatic medication, most diabetic medications, you have to worry about risk of pancreatitis. Next slide. TZDs. I love Actis. It is positivity is low cost. I get a lot of patients on it, but that drug I think has a kind of a bad name because of some of we'll talk about the bladder risk and stuff, but it is a good drug. It will move. It delays the progression of insulin. So I try it on patients before I would give them insulin a lot. It also has a low cost with it. So it's been around for a while. And it works through improving glucose and lipid metabolism. So also our patients that have hypertriglyceridemia would be another good one. They have triglyceride levels in that upper 300-400 range, a good drug to help with that lipid metabolism. So we'll use that on a lot of our patients that have hypertriglyceridemia and lipid issues. Next slide. So these are the considerations before starting, making sure that none of this is, positivity that would cause you to not want to start it. So slow onset of action, meaning that it's not like your sulfonylureas. I mean, it's going to work over the day, but it's kind of more like a metformin. It kind of runs across the entire day. Left ventricular heart failure. So this is, again, the weight gain issue. A lot of people talk about weight gain on this, but it's more a fluid type of weight gain that we tend to see. And anyone that has CHF just should not be using this medication. Our women over 65 postmenopausal probably shouldn't start the medication. Also, if they're over 65 and have this high risk, or 60 and they're already on some type of osteoporotic medication, we would not want to start it. After about 5 to 7 years of use, also, you could also consider stopping it just due to some of this fracture risk that goes on as well. And then the bladder cancer, you'll hear most often that will be the patient comment. Well, I heard it does that, and they did some looking up, but it actually has been disproven, and it's still is out there in verbiage. But as far as bladder cancer risk, I guess maybe if you had it, I wouldn't start it, but that was disproven. All right, next slide. GLPs. Our favorite, or my favorite, because of the once a week use on the Trulicity, the Bydureon, and the Ozempic. So the dailies are Victoza, and the twice a day is the Byetta. So these increase glucose levels when stimulated with food, and these stimulate the pancreas to secrete more insulin. I always tell patients, it kind of pings the pancreas and says, do a better job. And then lower in the system with the endocrines and the GI motility and the GI hormones at the small intestine level, it excretes some of it and also gives that sense of fullness and feeling fuller longer and getting some of that weight loss. So low risk of hypoglycemia, weight loss is occurring, no renal issues on that. So that's another great thing with this drug. And then the huge reason is cardiovascular risk, death, reducing risk of stroke and heart attack. It's not a preventative, but if they have known cardiac disease, this is an excellent classification of drug to be using for them. Some of the things to think about is on the next slide. Before starting the drugs, pancreatitis risk. So that was where Dr. Giordano just said that she probably wouldn't start it. It is pretty much a no-no for me if they have known pancreatitis. Now, if they maybe had it 10 years ago and one time and never again since, you potentially could use it cautiously with that. But any type of recent or reoccurrent and high triglycerides, I would strongly avoid the use of this classification of drug. Gastroparesis, again, it's not completely contraindicated, but you would really want to say, like, how severe, do they have it? Are they actually on meds because of gastroparesis? Do they dose their insulin after meals because of gastroparesis? Those would be another reason I would potentially not start it, because it is going to slow down GI motility. Talk a lot about medullary thyroid cancer. So that's the commercials that kind of inhibit us and make it difficult for us, because people are like, well, I heard I have thyroid cancer and my mother had it. It's not your classic papillary or follicular thyroid cancer, the most common, but the genetic mutations of thyroid cancer that you would not want to start this. And then the other reason is, the once a week and daily types of medications, which would help patients for the most part. Next slide. SGLT2s, Dr. Giordano's favorite medication. Back slide, please. SGLT2s, there you can see all the generic, in parentheses is the brand name drugs. I won't read them off there to you, but it reduces and lowers blood sugars by causing the kidney to remove sugar from the body in the urine. That's a simple term. Honestly, that's the best way to explain it to the patients. and they can understand that classification a whole lot better. The great thing about this classification of drug is both reduces the risk, cardiovascular risk, and also is used in our heart failure patients. And there I have it. I'm like, did I put the protein? Improve proteinuria and renal function and slowing the progression of renal disease. So this classification of drug is also being used independently of diabetes for some of the renal patients, and our cardiovascular patients definitely with known diabetes want to be on this classification of drugs. So the two though that are Jardiance and Farxiga. So the Invokana, canagliflozin doesn't have those indications as the other two do. Weight loss, I just had a patient today, thrilled, has lost about 10 pounds on the drug, low risk of hypoglycemia. And then it is an oral agent versus the GLPs. Your patients that just don't want to be on injections, a good option for you. Next slide. Considerations to start this is UTIs. That's probably the biggest thing. It doesn't stop you from using it if they've had a UTI. Again, I think you need to go into the history. How often do you have one? One every 3 to 5 years? Okay, you can do it. But one every twice a year you have it. Your little old ladies that are, 75 years old, and you might want to consider it. Pyelonephritis would be another one that you would not want to do it. There is some higher costs involved, but it is getting better. We're also seeing some of this risk of ketoacidosis, euglycemic ketoacidosis, a lot in the hospitals. So teaching your patients to, again, stop this medication if they are dehydrated, if they're having significant, fevers, any amount of dehydration, they should be skipping this drug for 2 to 3 days. They should be stopping this drug prior to surgeries, 2 to 3 days. Yes, their sugars are going to go high, but it's okay. So there are, that risk needs to be talked about pretty much on a daily with, or not on the daily, but every visit when they're on these medications, making sure you're reiterating hydration, stopping the medication during dehydration. So that next part talks about the volume depletion and that type of thing. These drugs also, if they're on an HCTZ, very low dose, something like 12.5, I've even had patients that are able to come off of it because of some of the diuretic effect that you have on that. Do not start this drug. We see this a lot in hospitalizations. Some of these cardiac patients, they would do them a great job to be able to be on this medication, would help their heart failure, but they have, a wound vac still somewhere on their limb or leg or thigh or something like that. You really need to wait for these to improve and heal completely before you would want to start this medication. Not to say that you couldn't, and then really be cautious. If they've had a history of this, you definitely may want to consider not utilizing it. And then the mycotic infections, talking to women and men about keeping themselves clean and dry to help prevent, they're going to be spilling sugars from their urine. And so increasing the risk of a dark, warm, moist environment, creating additional fungal type of issues for them. So again, it's not that you can't use it. Usually I kind of say 2 strikes, you're out. So, the first UTI, the first fungal, we'll treat you, we'll do okay. If the next one comes within 6 months, we're probably looking at the need to stop it. If the next one doesn't come for 2 years, it's okay. Treat them again. It potentially is that maybe their sugars are running higher. So again, good history on some of these patients, because sometimes it's not a no, not ever, but definitely need some monitoring with some of these classifications of drugs. I hope that was fast enough.
Thank you so much. You did great. That was awesome. No, we really appreciate it. And that was excellent. It was really easy to follow along, even for somebody that's not, involved with the treatment. But thank you so much. Really appreciate that. Does anybody have any questions or comments? I saw the comment of Jackie saying she started Ozempic this week. Awesome. You'll have to, let us know how that goes for you.
That was a great review, Melissa. I
Thank you.
just tell you guys that the ADA just came out with their newest published guidelines for January of 2022. And I really like in the guidelines, there's pharmaceutical use for basically all these different drugs, kind of the side effects, the things to watch out for, the benefits, especially cardiovascular benefits. They have a whole column of the cardiovascular and renal benefits. So I would just recommend that you check out the ADA guideline from January of 2022. The chart is awesome and it's pretty up to date.
Great. Thank you so much, Dr. G. Really appreciate that. Dr. Polywall?
Yeah, thank you for the presentation. Just want to comment that I don't know whether with this starting of the new year, something has changed. But since the new year started, I've been getting hard time for all this new year medication. Patients are calling me because they have a higher copay or prior authorization and things like that. So I'm not sure. And going back to the presentation, okay, I wanted to ask regarding that metformin extended release, especially for that 1000 milligram, there are two types of metformin. Is there any difference in efficacy or anything in the two type of metformin extended release?
The difference you mean between the ER and like the XL formulas?
Yeah, one comes with OSM, Osmo something. I mean, is there any difference? I never looked into it.
I don't know the answer to that question, to be honest. Dr. Quinn, do you know? Did he still stay on?
Yeah, I'm still here. If you're just referring to the different salts of the formulation, there is no difference in terms of efficacy.
Okay.
I've actually looked that same thing up myself before because I've heard somebody say that the extended release wasn't as efficacious, but there's no data. The articles that I was able to pull up, there's no data. They're both equally efficacious.
Okay, okay.
I also sometimes think you have to kind of, you're being truthful with your patient, but I think you need to kind of, sometimes when they can't tolerate it, like I use that twice a day dosing to try to like get them over the humps and use that slower release to kind of just get them there, you know, and sometimes it's the talk that you need to use to kind of get them to do it and say, well, oh yeah, you were on regular metformin. Let's try the ER and let's try the XL. And it's just they like to know that there's a little bit of change, you know, and then I don't know, sometimes I feel like I get some tolerance out of my patients when let's try twice a day dosing, even though I know they could take it all at once and that might help them. Let's take it before meals and, you know, okay, it doesn't work. Let's try it right before bed because you'll go to sleep and you'll be fine. So you just kind of, whatever scenario they give you, I try to give them a little twist to do it a little bit different and then maybe they'll tolerate it better. And there's really no difference.
I started out with metformin, the regular, and then they moved me to extended release. And then they moved me to 2 500 milligrams in the morning and 2 500 milligrams at night. And I had, I guess you're calling it renal problems when it's explosive diarrhea. I didn't get to sleep all night. I couldn't even make it to the bathroom. So then we tried I forgot the name of it now, but it's one you take in the morning and it's supposed to work, but it doesn't work as well as the metformin. So this week we're adding the Ozempic. So
there's some
I'll know them all.
Yeah, and there's some patients it's just not going to work, and if they have that bad of diarrhea, no medicine's worth that. There's other ones out there, and there's some out there that don't have the GI side effects. So you got to get your patient comfortable, because no matter what, if they aren't going to take it, then you're not doing them.
No, I took it. I was afraid not to. Now I'm just taking one in the morning and one at night, and then the other.
And know that at least taking some amount of the medicine is still going to help. So, you know, if you can't get to the 2000 in a day, then, you know, 1000 is still going to do a little bit. And again, working it with metformin in conjunction with the GLPs and the SGLT2s is better than not being on it at all.
I have one more question. I mean, especially with this GLP-1 agonist, for example, the Trulicity or the Ozempic, for some patients, I've noticed that even when you keep increasing the dose, you don't notice that weight loss or better blood sugar control. Have you noticed anything like that? Like you get initial response with Trulicity or Ozempic for the lower dose, but when you try to keep increasing the dose to the max, you feel that it's not really showing the same benefit.
I don't know what you guys see clinically, but it was studied with the
Sometimes-
Trulicity dosing, and there really wasn't a significant improvement in A1C reduction or weight loss when going up in the Trulicity. It was only a couple pounds difference and maybe 0.5% A1C reduction when going from the Trulicity 1.5 up to the maximum. So at least with that medication, there isn't much of a difference. I have seen improvement switching from Trulicity to Ozempic, a little bit more weight loss and A1C reduction. I don't know if Dr. Giordano and Melissa have seen similar things.
I would agree with that. Sometimes I've also seen changes from Victoza to Ozempic, because I've had patients that have been on Victoza for a while because they're 5-6 years, and these other drugs weren't affordable at 5-6 years ago. So I've switched patients from Victoza to Ozempic and have seen improvement in A1C and weight loss. I think weight also is probably my bigger thing. I don't see with the Trulicity as I go up in dose. I don't think they keep. And it's a patient thing too, it's a learned behavior. So it kind of, I tell patients, it's going to motivate you. It's going to change your sense of fullness. And you have to listen to that and not kind of out eat that sense of fullness, and keep listening to that your body is full, and kind of learn that the smaller portions and that you don't need it. And then maybe you will continue to, lose more weight. But I agree, none of them continually lose more weight, but definitely on the onset, which I think it helps motivate patients. But keep losing weight, I don't think any of them keep losing weight unless they're doing other things.
I think that's a really excellent point, Dr. Polywall, that you bring up about really any weight loss drug, or even surgeries, bariatric surgeries, which are some of the most effective things for weight loss. What you typically see in bariatric surgeries is weight loss and then a plateau. And we think of that as success, right? If a BMI actually stays stable and it doesn't actually continue to climb over time. And I tell patients that same thing when I'm talking about a weight loss drug, whether it's Wegovy or these GLP-1 receptor agonists, that, your BMI may eventually flatten out and you may not lose weight. But the great thing about that is that's success too, and that we're not continuing to gain weight for a lot of people who struggle with weight gain and appetite. So I think the absence of weight gain is a success story in itself for a lot of our patients, and a stable BMI, especially when they come to you saying that they've just progressively gained weight through adulthood.
Thank you so much. Very great questions. Dr. Polywall, I'm sorry, I didn't mean to cut you off. You have more to say. We still have 6 minutes, but yeah, those are really great questions, and I appreciate the feedback for sure. All right. Does anybody else have any comments or questions they'd like to add? Well, I appreciate everyone today. Thank you so much. You guys are really great, and the patients, and just it's a safe space, and everybody understands that things happen. So please don't worry about that at all. Our next session is going to be on the 23rd, a day after my birthday, everyone. Gifts are welcome. I'm just kidding. And Aiden Hader will be discussing an intro to adrenal diseases. So I look forward to seeing everyone, and have a great week. Thank you.
Thank you.
Everyone.